Okay. So thank you for that introduction. I won't introduce myself again, but before I start, I just wanted to emphasize that this work was actually led by one of my colleagues, Bushra Farouk. She couldn't attend today, so you've got me presenting instead. Bushra used to be one of my colleagues on the Manchester Self-Harm Project, but she's gone off to be a high-flying doctoral student down in Bristol with the fantastic group there. So yeah, unfortunately she couldn't be here today, so you've got me instead. Hopefully I will do justice to her fantastic work. So the paper that I'm going to present today is on self-harm among ethnic minority children and adolescents. Okay. So just a bit of background, which I'm sure most of you are probably already aware of, but I'll go over it anyway. So self-harm among children and adolescents is recognised as a major public health concern. That's given priority. Children and young people are a priority group in the National Suicide Prevention Strategy for England. The reason for this is because there's quite a lot of evidence, quite a lot of papers have been published showing that there is an increasing incidence of self-harm among children and adolescents. However, whilst we have this sort of broad knowledge of this increase, we don't really know much about how this breaks down into different ethnic groups. So we don't know about self-harm characteristics or outcomes in ethnic minority children and adolescents. So the work we're doing is, or we did, was based on data from the multi-centre study of self-harm in England. I'm sure many of you are probably already aware of our study, but just for anybody who isn't, I'm going to very briefly go over that as well. So the multi-centre study is a collaboration of very high quality self-harm monitoring projects based in Manchester, Oxford and Derby. We've been running since 2000. We collect data on all emergency department presentations for self-harm at our respective study hospitals. So in Oxford, that's one hospital, in Derby, it's one hospital, but in Manchester, it's 3 hospitals. We have very, very robust data collection methods and very excellent teams with us that go out and actually collect this data. And it's considered the gold standard of data collection, sort of epidemiological data collection on self-harm in the country. Okay, so again, I'm sure you're mostly familiar with this, but just in case anybody isn't, the definition of self-harm that we use in the multi-centre study and in the Manchester Self-Harm Project is one of self-harm being defined as any act of intentional self-harm or self-poisoning, regardless of intent. This definition is in line with UK and European research on self-harm, where suicidal behaviours are seen as a spectrum. So part of the reason why we don't really take account of intent in this definition is because intent is actually a very difficult concept to pin down, and it tends to change. If you ask somebody sort of at the moment they're in crisis, they may have one opinion. If you ask them 5 or 6 months later, which is when a lot of work is carried out because it's sort of retrospective, they may have a different answer. And even within, you know, a particular period or a particular episode of self-harm, people's intent tends to change. So we use this idea of a spectrum and have a broader group of people that we collect information on. Okay, so the aims of this work in particular was to investigate rates of hospital emergency department presentations for self-harm in different ethnic groups in children and adolescents. To identify differences in clinical and demographic characteristics, including deprivation, methods of self-harm and problems precipitating self-harm, and look at the individual ethnic groups, and in quite a lot of cases this is compared to the white group of children and adolescents. We also investigated 12-month self-harm repetition and mortality following self-harm, which I forgot to mention when talking about the multi-centre study, is we also link our data to NHS digital mortality information, and we're able to look at what happens to people after they've attended the emergency department in terms of mortality. So for us, really, the main outcome is often suicide, but we have information on everybody and different causes of death. So the study population we looked at was children and adolescents aged between 10 and 19 years who presented for self-harm from January 2000 to December 2016. Now you might look at this and think, well, that data is a little bit old, which it is, unfortunately. We are a little bit further on in our data collection now, but at the time that this was carried out, we do tend to have a lag in our data collection because of the very, very detailed and rigorous methods that we use, which enable us to capture all episodes of self-harm, as opposed to administrative databases, which only capture about 50% of cases. So it does mean we have a lag, and we were very unfortunately impacted by the pandemic, which meant we could not go onto hospital sites for 2 years or more in some cases. And we do go on site to collect data, so we do have a bit of a lag, but we're trying to catch up now. Yeah, so hopefully we'll have more up-to-date data soon, but we do have follow-up mortality data up to 2019. So the groups we looked at, we unfortunately had to use very broad groups because the coding around ethnicity, it is improving, but in 2000 it was not very good at all. And across the multi-centre sites, Manchester does use more detailed codes. We use the ONS codes to categorise ethnicity, which, you know, are still limited in themselves, and, you know, more work needs to be done in that area to to really capture the more sort of the depth of differences between, you know, particular communities and groups. But not all of the sites in the multi-centre study actually have that data, so we were only able to round into these really, really broad groups. So what we're looking at here is a really broad overview rather than a detailed account. So the groups that we compared were white, people of Black ethnicity, South Asian ethnicity, and this kind of group of everybody else of non-white ethnicities, which is very, very broad, so Chinese, mixed ethnicity, etc. Okay, so the results that we got, we found there were the sample, first of all, there was 22,000 presentations within our sample. Those presentations were made by around about 15,000 individuals, excuse me. The reason for there being more presentations is, of course, because some of those individuals present more than once during the study period. Data on ethnicity were available for nearly 12,000 individuals. So there's around 3,000 people, children and adolescents, where ethnicity was missing. And again, this is a chunk of this anyway is likely to be a sort of historical with data coding, which was very, very poor early in the study period. Obviously, we get our ethnicity information from the hospital records, and if it isn't coded in the hospital records, we can't code it either. So yeah, most of those will be sort of early on in the period, and from sort of the well, after 2010 it improves. I think it might be 2013 where it gets actually quite good. I can't remember off the top of my head, but the later period, like, it is encouraging that, you know, the later data is much more comprehensive and does tend to use those ONS code, which, as I've said, are limited but are better than these broad categories. But earlier in the period, there was a lot more missing data. So that's probably part of the reason why there's missing information on those 3,000. So in terms of the sample, as you might expect, because we do tend to find like majority white samples when we look at contact with services, over 85% of the self-harm among children and adolescents were people from white backgrounds. About 3% were people of Black ethnicities, and 5% were people from different South Asian communities, and just over 6% were this other sort of combined non-white group. Okay. In terms of demographics, there was overrepresentation of girls in ethnic minority groups, especially among those of South Asian ethnicity. Just to be clear, girls are overrepresented in self-harm generally anyway, so that's true of the white group as well. But in the South Asian group, there was a very pronounced sort of the ratio of girls to boys was quite a lot higher than any of the other groups. The other thing that Bushra looked at was deprivation. and that was using index of multiple deprivation score, and you can see the chart on the right here, where the blue part is the least deprived and the grey part is the most deprived. And Busher found that children and adolescents from Black, South Asian and other non-white ethnic groups were more likely to live in areas of higher deprivation. Now, as we also know, self-harm is often linked to deprivation, so that's one of the issues that, you know, probably needs more work and more investigation in the future. Excuse me. So in terms of rates of self-harm, there were higher rates of self-harm among the white children and adolescents, which again you might expect from them being the largest part of the sample, but there were significant increases over time in all of the groups. And if you look at this graph here, I mean, just from eyeballing this graph, you might be able to see that it looks like the difference between the starting point and the ending point. This data is from 2009 onwards, because we have more complete ethnicity data from 2009 onwards. The difference in the white group seems to be smaller than the difference in the ethnic groups. And indeed, that was found statistically as well. The increase was greater among increase in self-harm over time was greater in the minority groups than in the white children and adolescents. And particularly the increase in other non-white people was very marked, and you can see that's the lightest blue line here. And some of this might be to do with coding and to do with the fact that people are being coded a bit more accurately than perhaps they were previously. But the increase is so large that it's likely that some of it is actually legitimate and is an increase. Okay, so clinical characteristics. History of self-harm was more common among white and other non-white groups. And that's self-reported history of self-harm. It doesn't rely on hospital attendance. Excuse me. One really important, and probably the most important result that we got from this work was that the Black, South Asian and other non-white groups were less likely and statistically less likely to receive a specialist psychiatric assessment compared to their white counterparts. And obviously there's, you know, a huge question of equity there. And that again is something that we need to do more work on, and really to sort of look into that in a bit more detail. So looking at the problems that precipitated self-harm, relationship problems with parents and siblings were more commonly reported by Black and South Asian groups. Other non-white children and adolescents more often reported mental health problems. Problems with drugs and alcohol were more commonly reported among both white and Black children and adolescents. So looking now at repetition and mortality, around 18% of, this is across the sample, around 18% of children and adolescents repeated self-harm within 12 months. It's actually slightly higher than the average, which is about 15 or 16% across all people who self-harm and present to hospital. Repetition was higher in white children and adolescents than those from non-white ethnic groups. Again, this actually may be somewhat of an artifact of the fact that we record repetition as a reappearance on our database, rather than any kind of self-report, because obviously we don't follow people up in that way once they've left the emergency department. And so it could be an artifact of the fact that white children and adolescents are more likely than non-white children and adolescents to come to the emergency department for self-harm in the first place. We did find that there was no difference in suicide mortality by ethnic group, but fortunately the numbers were very, very small, so we really couldn't have detected a difference there anyway. Okay, so just moving on to a few implications. So presentation to hospital following self-harm is a key opportunity for intervention, and it is vital to ensure equitable access to services, including specialist psychiatric assessment. And as mentioned before, that's a really key thing. You know, I mean, we say this at the end of most of our presentations, that the NICE guidelines recommend that everybody has a specialist psychiatric assessment when they present for self-harm. and the fact that there's this identifiable inequality between children and adolescents who are white and children and adolescents from ethnic backgrounds. You know, it's a real issue and something that really needs to be, you know, picked up on and resolved. Easily accessible and culturally adapted mental health service provision for ethnic minority communities would be beneficial, and culturally adapted resources and psychoeducation on mental health and self-harm for parents and carers is also one of the recommendations made in this paper. And that's it from me. Thank you very much for listening. If you have any further questions about this or want any further information, I think we'll probably send the paper itself out as part of the post event information that we send, but you can email me at this email address. Thank you.